So today we'll be discussing on the drugs that we use in the treatment of bronchial asthma. The pharmacological agent that we use in the treatment of bronchial asthma can generally be grouped into two. There are some pharmacological agents that what they normally do is that they just help to relieve immediate attack. When somebody have immediate attack of bronchial asthma, which we refer to as asthmatic attack, they help the person to solve that issue. So we refer to them as the relievers. So the relievers are those drugs that help to solve those issues of immediate attack. You just want to solve the issues. How do they do that? They help to dilate the bronchi. They are also called the bronchodilators. So the first group of drugs used to treat asthma are the relievers, and they are also called the bronchodilators. They are the bronchodilators. Then the second group are what we refer to as the preventers. The preventers are also called the controllers. They help to prevent continuous asthmatic attack. They are called the preventers, also known as the controllers. They help to prevent inflammation so that asthmatic attack will not be continuous. So that's the two group of drugs that we use in treating bronchial asthma. The preventers are the ones that we help to prevent further attacks, but the ones we use to treat immediate are called the relievers. So we want to talk about each of them. So we'll start with the first, which is the bronchodilators. That is the relievers, the one that you just use when somebody actually needs help immediately. So next, we are going to discuss on the relievers. The relievers that helps to actually relieve immediate asthmatic attack. These relievers are things that can actually make the bronchi to become dilated, because in asthma the bronchi becomes constricted. You get now? So we want something that will make the bronchi to become dilated. And one of these bronchodilators or the relievers is what we refer to as beta 2 selective agonist. Beta 2 selective agonist. Beta 2 selective agonists, however, they are drugs that they actually helps to bring about dilation of the bronchi. How come? They actually act on epinephrine receptor. The receptor for epinephrine actually have the following receptor: alpha 1, alpha 2, beta 1, beta 2. If you give somebody epinephrine, what will happen to the person's bronchi is that it becomes dilated. But we don't normally use epinephrine because epinephrine does not only bind to beta 2 receptor. It's beta 2 that you will see in the bronchi where we need the bronchi to become dilated. Epinephrine will act on beta 1, which is in the heart, and make the heart to start to beat faster, causing tachycardia. That is not what we need. So we need what can just act only on that bronchi. That's where we need it. That's the best place it can work. So that's why we go for selective beta 2 selective agonists. These drugs, they are agonists. That means when they bind to this selective beta 2 receptor, they work as if it's the epinephrine that is there. They cause bronchial dilation, but they don't act on other regions like the heart, because the beta 2 receptors are majorly found in the bronchi, in the airway. You get now? So these beta 2 selective agonists are grouped into two. Some of them act for a longer time, some act for a shorter time. The one that acts for a longer time I refer to as LABA. Then the one that acts for a shorter time I refer to as SABA. So this is SABA, short acting beta 2 agonist. Yes, short acting beta 2 agonist. They bind to beta 2 and act as if it is epinephrine and cause bronchial dilation. You must know example of SABA, short acting beta 2 agonist. Salbutamol is an example. Albuterol is an example. Terbutaline is an example. Levabuterenol is an example. Metoproterenol is an example. So you must know the examples of SABA, short acting beta 2 agonist. Then also you should know the example of LABA. LABA means long acting beta 2 agonist. These they actually bend and act longer than SABA. Example is where we have sameterol and formoterol. They can actually have clinical uses. We'll talk about their clinical uses later of LABA. We'll talk about them later. So these are the first group of bronchodilators, the first group of relievers, drugs that can help to bring about relief for this asthmatic attack. Let's talk about the mechanism of action. How does this drug act? These LABA and SABA, those selective beta 2 agonists. Simply put, they bind to beta 2 adrenoceptor, the receptor that epinephrine is supposed to bind to. And when they bind to it, they stimulate adenine cyclase. Adenine cyclase is the enzyme that helps to form CAMP, cyclic AMP. Yes. So when they activate adenine cyclase, cyclic AMP is formed. the increased production of cyclic AMP occur, and that causes relaxation of the smooth muscles that you see in the bronchi. These muscles that were contracting before to make the airway narrow, they now relax. And also, we said in bronchial asthma, something else that happened is that there's, in the previous video, we mentioned that there's microvascular leakage. Fluid also come into the lungs. They also inhibit microvascular leakage. So this is how they actually act. They bind to the receptor for epinephrine selectively, selective beta 2 agonist specifically, and then they prevent the contraction of smooth muscle. They cause smooth muscle relaxation. All right. They also inhibit inflammatory action. So now let's move on to the second group of drugs that we can actually use as relievers. The second group of drugs that we can use as relievers are referred to as the muscarinic antagonist. Muscarinic antagonist. What do we mean by muscarinic antagonist? Remember, an agonist binds to a receptor and stimulates the action that hormone that's supposed to bind to it will stimulate. However, an antagonist binds to a receptor and does not stimulate the activity. It just blocks that receptor. What is supposed to bind to the receptor cannot bind anymore. In the bronchial airway, there are different types of receptors. Epinephrine receptor is there, beta 2 is there, and that's what those first drugs we mentioned, SABA and LABA, that's what they bind to bring about their action. However, there's another receptor that is there, which is called the muscarinic receptor. The muscarinic receptor that is there is for the binding of acetylcholine. Acetylcholine binds to muscarinic receptor, and once acetylcholine binds to muscarinic receptor, it makes bronchial constriction to occur. So we need something that can block this bronchial constriction. We need something that can block this muscarinic receptor, so that when acetylcholine come and want to bind to muscarinic receptor, it will have nothing to bind to, and as such cannot cause bronchial constriction. And that's what we refer to as muscarinic antagonists. They are the job. They are the master of this job. They block muscarinic receptor that is in the airway, and when acetylcholine comes to bind to cause constriction, it has nothing to bind to. Example of muscarinic antagonist is where we have atropine sulfate. Another example is what we have ipratropium bromide. These are examples of muscarinic antagonists. You must know them. Muscarinic antagonists: atropine sulfate, ipratropium bromide. How do they work? You can see the mechanism of action. They competitively inhibit the effect of acetylcholine at the muscarinic receptor. That's what they do. So that's a very easy one to remember. And once they do this, they help to prevent that excessive contraction. They block the contraction of the bronchial airway. And once they block that contraction, the airway will be patent to be open and to be relieved from stress. Now, let's now move on to the third group of drugs, which we refer to as methyl xanthine agent. Methyl xanthine agent include aminophylline and theophylline. They also cause relaxation of smooth muscle by increasing calm. They are among the group that are under relievers, and they're also under preventers. So you have seen the three group of drugs we mentioned that they are under relievers that helps to relieve asthmatic attack. They are the selective beta 2 agonist, the SABA and the LABA. We also have the muscarinic antagonist, so you have the pratropium bromide, and we also have the atropine sulfate, and also we have the methyl xanthine agent, where we have aminophylines and theophylines. Now, let's move on to what we refer to as the preventers. The preventers, we said, they are also called the controllers. They help to prevent continuous asthmatic attack. How? The reason why somebody may have continuous asthmatic attack, one of the reasons is because there's inflammation. Inflammation of that airway. The airway is very narrow, as we said in our previous video. Very narrow. Now imagine it is inflamed, it is swollen. The airway will now be very small. Imagine the wall of the bronchi is swollen. The airway is now be very narrow. So you can, any little thing will just block the airway. So you need what we refer to as anti-inflammatory drugs. Things that can actually cause that inflammation to reduce, and to be hard for the airway to just get obstructed, and the person will not be having recurrent attack. So let's talk about these preventers. The first preventers are anti-inflammatory drugs. Anti-inflammatory drugs. Yes, the anti-inflammatory drugs are drugs that helps to actually fight against inflammation. From what anti-inflammatory? Some of them we can take them through systemic routes, while others you can take them through inhalational routes. Based on this, they are grouped into systemic glucocorticoid and inhalational glucocorticoid. Under systemic, we have budesonide. We have prednisolone. We have prednisone, methylprednisolone, and triamcinolone. Prednisolone, prednisone, methylprednisolone, and triamcinolone. Then under inhalational, that's where we have budesonide, beclomethasone dipropionate, and fluticasone. These ones are inhalational glucocorticoid. What do? They help to fight against inflammation. Inflammation, whenever somebody have asthmatic attack and inflammatory cells, already seen that in our previous video, come into that region. It causes inflammation. And one of those inflammatory cells is the eosinophil. Yes, eosinophil is one of the inflammatory cells there. Cause inflammation. And so these drugs help to prevent inflammation. And when there's no inflammation, it is hard for asthmatic attack to keep on occurring, to keep on reoccurring. So that's how this drug actually acts. They inhibit eosinophil in the airway. So now we can now move on to another group of drugs which we call the leucotriene pathway inhibitor, another preventer. So we've seen one preventer, anti-inflammatory drugs, yes, it can be inhalational or systemic. Next, we want to look at leucotriene pathway inhibitors. Now, I explained this in the pathophysiology. Leucotriene, what are leucotriene? Just know it this way. Leucotriene simply are group of compounds that are derived from arachidonic acid. Just know that arachidonic acid is actually a fatty acid that has 20 carbon atoms. Arachidonic acid has what we can actually give rise to prostaglandin or leucotriene, depending on the enzyme acting on it. Arachidonic acid is being acted upon by cyclooxygenase to form prostaglandin. It is being acted upon by what we refer to as 5-lipooxygenase to form what we refer to as leucotriene. So do you get the point now? Now, leucotriene, we've seen that leucotriene C4 and D4 are very, 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 very important in causing those constriction of the bronchi. In fact, the most potent constrictor is this leucotriene. So if you can inhibit leucotriene, you can actually help somebody that have asthmatic attack. Now, we want to talk about leucotriene pathway inhibitors. Leucotriene pathway inhibitors. Leucotriene pathway inhibitors that we have is one, any drug that can inhibit 5-lipooxygenase. Because you remember, I said this 5-lipooxygenase, there's the enzyme that helps to form leucotriene, C4 and D4, those leucotrienes. Good. So 5-lipooxygenase inhibitors such as xylutine can be used in the treatment of bronchial asthma. It's a preventer. It prevents leucotriene from actually being formed. And once leucotriene is not formed, because this enzyme 5-lipooxygenase is inhibited, the person will have rest. The person will be resting, not having continuous asthmatic attack. Also, after leucotriene is being formed, it will need to bind to a receptor, leucotriene D4 receptor. If there's an antagonist, what can actually block that receptor so that leucotriene will have nothing to bind to? If it have nothing to bind to, it will not be able to act. That's why we have leucotriene D4 receptor antagonist. What can block that leucotriene receptor? An example is where you have Xifalucas and Montelukast. So another group of drugs that we can use to treat Xifalucas and Montelukast. So these are examples of drugs under leucotriene pathway inhibitor. One of the drugs we mentioned blocks the enzyme, inhibits the enzyme 5-lipooxygenase, and the second we mentioned actually helps to antagonize the receptor. That's leucotriene D4 receptor antagonist. So xylutine is among the leucotriene pathway inhibitors, but actually it inhibits 5-lipooxygenase. Then Xifalucast and Montelukast, they actually are also under leucotriene pathway inhibitors, but they actually do what? They actually antagonize leucotriene D4 receptor. Mechanism of action, they competitively antagonizes with leucotriene D4 receptor. Very easy to remember. Next, we move on to mast cell stabilizers. Another group of drugs that you can use as preventers. Mast cell stabilizers. So let's talk about mast cell stabilizers. What are mast cell stabilizers? Remember, in our pathophysiology, we said it is the mast cells that release those granules. And once those granules are released, what happens? Once the granules are released, the person starts having an attack. Yes, because the granules are what contains those primary mediators. You get now? Now, if the mast cell is very stable, so even though those granules are released, the person will still, the granules will not be released because the mast cell membrane is stable. So they will not just be releasing the content easily. That's mast cell membrane stabilizers. An example, chromoline, also known as nedocomil, is an example of mast cell membrane stabilizers. You get now? So that's that for that. So other preventers that we have, that's why we have what we refer to as the Methyl Xanthine agent, phosphodiesterase inhibitor. We've seen them before. Aminophylline and theophylline. They said they are under preventers and relievers. We've seen that they increase cyclic AMP and then cause relaxation. We've already talked about them. We also have humanized immunoglobulin G monoclonal antibodies. They can also be used. Then we also have anti-immunoglobulin E monoclonal antibodies. They can also be used as preventers. Remember, immunoglobulin E is what binds to the mast cells to make them to actually become sensitized and to undergo rupture and release their content. So if you can actually have an antibody, things that can, if you have an anti-immunoglobulin E monoclonal antibody, they inhibit that immunoglobulin E for performing that action, and you can use them to actually treat bronchial asthma. So these are some drugs you can use to treat bronchial asthma. Let's quickly talk about combination therapy. Combination therapy, simply, we are talking about you don't just give a drug for bronchial asthma, just give a drug and that's all. No, instead, we prefer combination therapy, giving more than one drugs. And the best combination therapy we use is what we refer to as LABA and inhalational steroids. You give LABA, inhalational, when we say LABA, long-acting beta-2 agonist, those formoterol and salmeterol, yes, LABA, long-acting beta-2 agonists, you give them with inhalational steroid, those budesonide, fluticasone, those ones are inhalational steroids. So you give them together. They are the combination therapy that we normally use. So combination therapy that is normally used is LABA and what? Inhalational steroid, inhaled steroid. All right. So you can use salmeterol and fluticasone dipropionate. This LABA, and this one here is what now? It's an example of inhalational steroids. All right. That's just one combination therapy. Other combination therapy can be done like using leucotriene receptor antagonist, montelukast and xifalucast, and glucocorticoids like those systemic glucocorticoids or inhalational corticoids. So this is another combination therapy. After knowing this combination therapy, let's talk about something very important, which we refer to as status asthmaticus. Let's talk about that. Status asthmaticus. This simply is an acute severe exacerbation. You must take note of this word. It's acute. It does not show too much sign. It just comes. It's acute. It is severe. It is very severe. It's an exacerbation. Like it's a worsened form of an asthmatic episode, and it is resistant to what? To outpatient treatment. The person has to come to the hospital. The person cannot treat that type of condition at home. So it is an emergency. It is a medical emergency that needs the patient to come to the clinic, to the hospital as soon as possible. When the person comes to the hospital, what will you do? What will you use to treat this person that have status asthmaticus? This person actually is suffering from a very severe attack. So you actually help the person by giving the person both systemic and inhalational anti-asthmatic drugs, both systemic and inhalational. That's what you use. Also, you assist the person because the person may be having difficulty with breathing and be having hypoxia and hypercapnia. Yes, hypoxia, that means the person will have reduced oxygen level in tissues and blood. The person will have hypercapnia, excessive CO2 level. You get? So you actually give the person oxygen. You administer oxygen to relieve the person of this stress. The person may be undergoing dehydration. You administer intravenous fluid. And also the person may be having respiratory failure. So you can assist the person if he is having respiratory failure. So in conclusion, all we've said in this tutorials is that pharmacological agent to treat asthma actually focuses on what now? The bronchial constriction. You look at bronchodilators and also the inflammatory drugs, the inflammation. So we use anti-inflammatory drugs and other preventers to prevent continuous asthmatic attack. So this is the actual point you should also know about. You should know about asthma. Watch this video continuously and get the point. Know those drugs. Know the relievers. The relievers include the bronchodilators. They also called the relievers, where we have things like selective beta-2 agonist, SABA and LABA. Know the example of SABA, know the example of LABA. Then you move on to muscarinic antagonists. Know the examples. The pratropium bromide, atropine sulfate. Know the examples. Then after that, you move on to when we talk about things relating to the Methyl Xanthine agent, aminophylline and theophylline. Move on to the systemic glucocorticoid, the preventer, systemic glucocorticoid, and the inhalational. Systemic, you remember prednisolone, methylprednisolone, triamcinolone. You get it now. Then you go to the inhalational. Remember budesonide. Remember fluticasone dipropionate. Remember this. Know that combination therapy is better. watch the tutorials continuously so that you get the points more and more. Thank you very much. We'll continue from ANS in our next class.